Welcome to the Glucose Never Lies podcast. I'm John Pemberton, a diabetes educator and researcher living with type 1 diabetes since 2008. I started the Glucose Never Lies website when my son tested positive for type 1 diabetes antibodies. In that moment, I realised I needed to build a resource strong enough to guide anyone who might care for him. At first, that meant writing clear, actionable management guides, but listening to Peter Attia's The Drive taught me something. Peter's conversations provide depth across nutrition, exercise, pharmacology, sleep, and much more. But I always find myself wondering, how does this information apply to people with type 1 diabetes? And this podcast is my attempt to fill that gap. I have access to the world's leading researchers and thought leaders in type 1 diabetes. That gives me a unique opportunity to combine lived experience, professional expertise, and cutting-edge science, and to share it all on here in conversation. But an important note, this podcast is for informational purposes only. These conversations share knowledge and experiences. They do not create a therapeutic relationship. So, let's get started. Welcome to Glucose Never Lies podcast. And this podcast is one based around women's health, particularly the menstrual cycle, type 1 diabetes, and what it means. And I'm happy to say I've got Dr. Cecilia Nobili with me from Italy. Hello, welcome to the show.
Thank you. Very good pronunciation of my name.
Well, I've just practiced it for 5 minutes, so it should be. Okay. So really, this is an area that a lot of the listeners have reached out and said, okay, we've got a lot of nice information about diabetes in general, but what about some female-specific stuff? And I'd obviously put out on a newsletter that I was having Dr. Jane Yardley on with an exercise perspective. I just recorded a very interesting one with Professor Eleanor Scott with regards to pregnancy and type 1 diabetes. And then Cecilia reached out and through LinkedIn and sort of said, what about the menstrual cycle and type 1 diabetes? At which point I said, do you know anyone? And then I got it back. The full information. This is what's going on. This is the situation. So I was like, oh, so you're saying you, which I love, because I think if you've got something to say, you should totally reach out and have the opportunity to say it. So first of all, well done for reaching out and, kind of putting yourself forward.
Thank you very much. I mean, your answer was quite unexpected to me because, I said, okay, I'm on the train. And then I will just write to him everything. That's it. And then we'll see what he picks up from that.
It certainly did the job. It certainly piqued my interest. And part of the reason why it piqued my interest is largely because you have type 1 diabetes yourself. You realized for yourself this was a challenge. And then obviously once you have that personal interest, it then sparks a whole load of creativity, a whole load of different way of thinking about things. So that should be really helpful for the listeners just to get a little bit of your personal story with type 1 diabetes, kind of how it came to be and how that shaped your moving forward into the clinical and also the research sphere of type 1 diabetes.
Okay, so I am 30 years old and I got my diagnosis actually at 25 years old. So it was not that much time ago. I was already an adult and I was already a physician. And that really changes all the perspective on that. I also had, quite a long honeymoon phase. Really appreciate that. Now that I'm out, I really appreciate that. And first, I wasn't thinking about doing this job. I am a pediatric resident. And in my last year, focusing, of course, on pediatric diabetology. And when I got my diagnosis, I was doing something that was totally something else, just internal medicine. And the actual lab results came back. They called me and they told me, oh, you have a really high glucose that day. You have diabetes. And I said, no. You got the wrong person. Those are not my exams. That was my first reaction. Then I just, waited 2 hours after I ate, doctors, physicians do that. And then I did my finger prick. It was more than 400 milligrams deciliter. And I was like, okay, there's a problem. Then we have to do something about that. And so they just gave me pens. And it was, lockdown. They gave me insulin pens. And they said, okay, this is the long acting. This is the fast acting. You have this, just follow that. And then in a few days, go to the diabetologist in your hometown and talk with him. And I was like, oh, really? Really? Do I have to do that? I was super shocked for days. And then I went to see my diabetologist, and she's really great woman, really good therapeutic, relationship. And she told me, you're an adult, you're a physician, you can do that. And the most important thing you have to think about is that you don't have to make your life revolve around your diabetes. You have to make your diabetes revolve around your life. And that's, the most, I think, positive message that anyone can give at someone who is at the onset. And so I started my trial and error phase during the lockdown. It was primarily about hiking in the mountains, which I really loved. And I would go on hypo every 2 minutes. It was super frustrating. My husband was looking at me and saying, okay, can we go home? I said, no, I don't want to go home. I'm going to correct this hypo and then we're going to hike. And it was terrible the first time. Lot of trial and error, lot of trying to read online, lot of reaching out to people, which is something that I really do. And, a little bit of effort. And then I started to do my hiking again. And that was, super satisfying. I was working, doing my hiking at weekends, and I said, okay, I can do it. And then I decided that I wanted to do this job as a pediatric resident. First, I tried to see if I wanted to be a pediatrician, because it's really important, of course, in this job that you want to be a pediatrician first, and then focusing on diabetes. And I really have to thank all the people that, tried to bring me into that. Because, at the beginning, I was just, to be like a little bit interested. I called people that were doing this job, reaching out and asking, okay, what's your job like? Please tell me something about that. And they would say, oh, we do diabetes camps in the mountains. We do hiking. And I was, oh, that's me. That's really me, the hiking part. And so I, just, little bit dove into that. And then I decided to do this. And I got my AID quite early, like 5 months into my diagnosis, because, I was going to do around stuff, working at nights, shifts. And so my doctor told me, okay, it's better on AID. And I was super lucky for that, because I know there's not a possibility for everyone, especially in the adult world, also right now. And then I started doing this job. I was, kind of mixed feelings, because I had my perspective and the patient perspective. I had the things that I was doing with myself, and the things that I'd observed with myself, and the things that the patients observed. And so I started a little bit, trying to merge this. And the cycle actually arrived a little bit later, the menstrual cycle, because it's not something that we are used to talk about openly. And it's just something that sometimes it's pointed out as, okay, something that happens. Maybe you should try to adjust your doses. But how much? Why would you do that? And so I started to do, first a little bit of research on myself. I noticed some patterns that we will talk about later. And then actually doing another study that was called the Sick Days Study, a study on intercurrent illnesses in children treated with the 70-ADG, I noticed that whenever I discuss this with adolescent girls or their parents, they would ask us, but why don't you do the same on menstrual cycles? It's just not manageable. It's much worse than a cold. You're asking me about cold, you ask me about fevers, you're asking me about gastroenteritis, but what about menstrual cycles? And so I said, okay, let's get back a little bit. Let's do, literature stuff. I started reading guidelines. I started reading, papers, but it's not that mentioned as much as it is perceived from the community. If you look on the internet, actually, or if you talk with people with type 1 diabetes, with women with type 1 diabetes, they have this experience that it's very clear for some of them. And it's almost invisible, like in the official documents. so much of online material, community content that addresses this and underlines how it is important for women with type 1 diabetes, but you don't have any structured recommendation for that. And this is how I started to think about doing a study on this.
Okay, so let me unpack some of that. So what you're basically saying is you got diagnosed with type 1. It changed your trajectory of things you were interested in. You obviously, which is great to hear, applied a lot of trial and error on yourself to find out what works for hiking, what doesn't, and realize that the textbooks, although they can give you a starting position, they don't give you what I'm going to do when I go for a hike. That can only be learned by the hard experiences of going low and adjusting, which is great to hear. And then obviously you then transformed your career into going into helping people with diabetes, which started off obviously as a physician, and then with your interests in the automated insulin delivery systems with the sort of intercurrent illnesses, and then obviously your own personal experiences, but then speaking to people and seeing online that actually there's this huge topic which affects half of the people with diabetes. And I think you were saying not all of the women will experience these differences with menstrual cycle, but a large proportion of them will. So, that's going to be 30 to 40% of the actual type 1 diabetes community who perceive and experience this massive issue that actually there's very little literature on. There's very few recommendations, if any. And yes, of course, you have to start with a learned experience. But if that's not in the official literature, then it's not getting talked about in clinic. So obviously that kind of takes there. But before we jump into your research, as someone who obviously doesn't experience a menstrual cycle, give me the dummy's guide of what it is, the sort of typical lengths of these cycles and these phases, and what it can mean for changing hormone levels and insulin levels. So kind of give us the basic 101 on what the cycle is and what impact it might have on diabetes or glucose control.
Yeah. First, so let's talk about the menstrual cycles. How much does it last? It's from 28 to 35, the normal length of the menstrual cycle. So if you have patients that have, earlier bleeding or later bleeding, you have to keep an eye on that. So that's really important from a physician perspective and also for a patient perspective. Keep an eye on that. Track it. Know how much long does it last for you. Always know that. So we have some phases around that, and clearly they can be a little bit different from patient to patient about the length, because it depends on the length of actually the menstrual cycle. You start the menstrual cycle when the bleeding starts, when the period starts, and that's called the early follicular phase. Then you have another 4 phases that are called mid-follicular, periovulatory. Periovulatory is when you have your ovulation, of course. It's around day 14 to 15, but not for everyone because it depends on the length of the menstrual cycle. Then the mid-luteal, and finally the late luteal. In these phases, you have hormones that change their levels. In the first phases, you have the estrogen. In the last phases, you have the progesterone. And it's actually the progesterone that gives us problems, okay? Because you have a relative higher insulin resistance in that phase compared to the previous one. So usually it's like that. You have like really good glycemia in the first phases, and then you see your timer range going down. And what you see actually from a patient slash physician perspective is that if you do the same stuff that you were doing the days before, it's really difficult to manage. I mean, we can also talk about, premenstrual symptoms and things like that, maybe emotional rawness, maybe hunger. And usually in the days leading up to the period, you want to eat pizza. You want to eat chocolate. You want to eat ice cream. It's not like this for everyone, of course, but for me, it is like this. For many of our patients, it's like this. And so you just want to really, eat these high carb, high fat meals. And then you go so high. And that's because of progesterone. Okay. And then all of a sudden, when the period arrives, you started going low. I mean, you can eat virtually anything sometimes, and you just eat like this super flattened curve. because the progesterone is not there anymore, and you start in having a little bit of estrogen. I hope that this is clear.
Okay. I
Can
think you've done a good job. I'm going to tell you what I understood of that. Being a person who has a very, very basic understanding of the menstrual cycle, I've just made some notes there of what you've said. So if anyone's listening, you can compare notes with me and see whether you've done better than me, or see you can grade me on how well I've done. So you've obviously mentioned at the sort of the start, which is the bleed, which is the early follicular phase, and that is typically a high estrogen, low progesterone state where you're most sensitive to the insulin, which means sometimes you can get away with eating more, but also it means the increased risk of hypos is quite a challenge at this point, especially because as you then go through a fairly steady phase where things are usual for you, then you have this 3 to 5 day period in the sort of luteal phase where the progesterone really ramps up. The insulin resistance goes hand in hand, so you'll need more insulin, but you also then have sounds like a very frustrating drive for foods that you would typically not want to eat if you're insulin resistant. Your sort of high carb, high fat meals. So you've almost got this perfect storm of insulin resistance, desire to eat things which will cause insulin resistance, and then obviously as a consequence, higher glucose levels, as well as potentially having symptoms emotionally associated with this, which is, kind of maybe feeling less emotionally well, frustrated because your diabetes control has just sort of gone out of the window. It doesn't sound fun, is what I'm saying. Yeah. And then you go from that to obviously then have the bleed, where all of a sudden you go from this very insulin resistant state to all of a sudden very insulin sensitive. So if you're not careful and you don't understand how this cycle works, you potentially could put more insulin in to cover this, and you think you still need it, but then you don't need it and you have a big issue.
Yeah.
Have I done okay there? Is that about right?
That's exactly how it is. I just want to stress one thing, because as everything else with diabetes, it's not the same for everyone, because we also have some patients that actually have some changes in the periovulatory period. So
so that's the average picture, and I think that's one thing on the glucose stabilizer for sure. We present the average picture, but we realize on that average picture you've got people so far one way who experience no symptoms, and some people like what you're describing there is the average. I'm on the end of the scale where things are just way worse than that. I am so insulin resistant and my hunger is all over the place. So we totally get it. We're just presenting a picture of typically this is what a lady will experience, but however it can be much more aggressive or difficult than that. And it can also, for some people, they don't experience those. So we appreciate everyone fits there. But as a typical presentation of somewhere to start, I mean, to me, that sounds like you're not going to be looking forward to that 3 to 4 day period and then the change of getting back to insulin sensitivity afterwards. When you've got a busy life, you've got other stuff going on, but once a month or once every 35 days, you've got this kind of 5 to 6 day period where things are going to be difficult, and you go and speak to someone about it and they don't really have a research understanding. There's not the academic papers. It's not talked about at conferences. The information isn't disseminated. So what you're then left with is a lot of anecdotal experiences, which are absolutely valid, but are not pulled together in something that helps us, certainly healthcare professionals and people with diabetes, know where to start in a safe and comfortable way and have a discussion. So if I see a young lady, like, this has already helped me. This has already helped me look at their download. It's already helped me think about how to have a conversation. But obviously, you've gone to the next step of going, okay, we understand this problem. We understand that AID systems may offer us something. Let's find out about what people's experiences are before we try and do anything. Let's understand it. So tell me a little bit about the questionnaire you developed. Tell me a little bit about what you found out.
Okay. Always, thinking about my own personal perspective and the things that the adolescent girls told me, I developed a questionnaire. And this questionnaire has now more than 170 answers. Is that sorry, John?
Yeah, people. Yeah, 170 people you've got. Yep, perfect.
Oh, okay, but can we redo that? Because I was like response, it was like something going on in my mind.
Yeah. 170 responses, 170 people. You've basically got a unique 170 people who responded to your questionnaire and given you 170 unique perspectives on their experiences.
Yeah, it's a multi-centric study actually. We are three centers in Italy. One in the northern part that's called Verona, one in the southern part that's called Messina, and there's us, Torino. So we developed this questionnaire that really focuses on first, the clinical part. What is the average length of your cycle? How much tampons or pads do you change during your cycle? Which is very important because it gives you the information if something maybe is wrong. Okay, because there are not, like questions that we usually do in the clinic. We don't ask this stuff, but we should because we have in front of us menstruating girls. So it's really important for their overall health, okay, to ask this. And then we ask about what's their perceived burden during the phases. What does it mean? It's like, simple question, like when you think about the days before the bleeding, how much of a burden do you perceive from 0 to 10? And so they just give us a number. And we repeat the same question for the days when you actually have the bleeding. Okay, it has to be really simple because it's for girls that have to keep the bleeding in mind. We can be doctors and talk about fancy stuff, but you do have the bleeding in mind when you think about the start of the cycle. And what I expected actually is that they will tell me like really bad score in the luteal phase, so in the days before the bleeding, and a better score in the days actually when the bleeding arrives. But sometimes it's like this. For many patients, it's like this. But for other patients, it's not. It's the opposite. And so I just asked them, why? Why would you say that? What are you thinking? What do you have in mind? And they will tell me, because they're gone hypo. I mean, for me, hypos are much worse than hyperglycemias because I have to really stop. For people with AIDs, sometimes you see the hyperglycemia, you just say, okay, my system is going to care for that. I just continue with my life. I'm going to check it later if it's not that high. With the hypos, you have to stop. You have to actually do something. So it's perceived for some of them like more of a burden. And I think that depends also on the algorithms, actually, because, the algorithms didn't factor in the menstrual cycle. Okay. The engineers, the people that actually studied that, didn't factor in something that periodically would happen to people, would happen to these 50% of people with type 1 diabetes, to the women.
Well, it's probably because most of the people doing it are men. We're going to be straight up. I don't know, but I should imagine most of the AID algorithm engineers are male. If I had my guess, it would be 90% of people. I might be wrong, and I'm happy to be wrong. And if someone from a company reaches out and goes, you know what, we are our engineers are actually 50% female, then fair enough. But I would put a strong bet in that you're probably spot on.
Yeah, we can call it a gender gap in care for women with type 1 diabetes because it is that actually. Because we don't have the literature, we don't have the recommendation, we don't have anything built for that. And so I think that as a community, as physician, as healthcare providers should really think about it as a gender gap and start asking the questions and start to reflect on that. And maybe the industries start to do something on that, actually.
Yeah, I agree. I 100% agree. Yeah. So you've identified this. So what I'm hearing is you developed this questionnaire. You found out to understand for each of these 170 individuals, what's their cycle look like? Days, are there potentially issues with heaviness of bleeding? So you can kind of characterize what their menstrual cycle looks like. And then importantly, what's the perception of how much this challenges you? And what you were expecting to find, which you did find in somewhat, was the insulin resistance part in the luteal phase where they're going high and all the things associated. That was annoying and definitely a problem. However, what you weren't maybe thinking you would see, which I came to see, was then when it goes into the early follicular phase, where the insulin sensitivity all of a sudden comes back and the insulin doses haven't been changed, or the thought process hasn't changed. It's the hypos, and because it has an immediate effect on your quality of life, because you've got to stop, you've got to treat it. Sometimes it makes you feel bad, and then you're driving in the situation, it messes around with your driving. At work, you're trying to concentrate, and it's kind of all off the place. So actually, that's potentially as much of an issue, if not more of an issue, from a quality of life perception and how you're feeling, than actually the highs, which, they're not going to stop you. They're annoying, but they're not going to stop you doing what you want to do. So that's interesting. And then, so you've got this information and you've found out these things. Where did you take that from here? Because obviously information is great and you've characterized this and you've identified these different patterns. What did you want to find out next?
First, actually, I took a step back because we talked about not so much literature about this, but there is something, especially in the last 2 years. We have some literature on the 70-80G, and it's really interesting from a researcher point of view because we have like 5 studies on the 70-80G, and they all have like from 12 to 16, 20 women with type 1 diabetes. And you can see different things because I think that there is one bias that we didn't talk through, not even right now. It's the fact that when you compare the early follicular phase versus the late luteal phase for women on MDI, it's different when you consider an algorithm that does something in between. Okay, so you have like this nice study actually on DTT that compares the early follicular versus the late luteal phase on 12 women on the 70-80G, and they go from the 85% of timer range to the 83% timer range. And first, when I looked at that, I said, okay, great result. My adolescents don't have the 85% timing range, so we have something to think about on that. So it's, really selected people. And also we don't see what happens in the between, because actually you start having your insulin resistance also in the mid-luteal phase. So if I think from a 70-80G perspective, the algorithm will start working on that and giving more insulin, so you have a better outcome in late luteal phase maybe than the mid luteal phase. So it's knowing your algorithms, knowing how they work, and then start to reflect what you can do actually about that, because every algorithm works in a different way. They factor in, the insulin that you've done in the days before in a different way. And this will reflect in a different way on your menstrual cycle that maybe is different from the others. I don't know if I gave you the whole idea.
Yeah, no, absolutely did. So obviously with multiple day injections, what you're saying is the adjustments are going to be down to the person, the user generally, to either up their basal insulin or make their carb ratios more aggressive, which obviously means that you have to have a good understanding of what's to come. You have to have practiced it. You have to think that it's going to be the same each time, which obviously isn't the case. So it strikes to me like the people who are injections are going to have a harder time with that, quite clearly. And then obviously these algorithms offer an opportunity to demonstrate that hard work for you, but that depends on the algorithm. So what you're describing is that most of the, 3 of the algorithms, certainly the 780G, the Omnipod 5 system, and the Cambridge system, what they do is they use the previous day's total daily dose to prioritize what's changing and maybe be more aggressive. And they vary in how they take the previous day's data, but most of them tend to prioritize the last kind of 3 to 5 days worth of data, which again, if they're in the mid-luteal phase, if it's starting to ramp up, you would think that those systems are going to get on top of things. In contrast, you've got the T-Slim where you set the basal rates and correction factors, and you would then have to have maybe 2 profiles or even 3 profiles. You would have to have one profile which has maybe a mid-luteal phase with a slightly more aggressive basal and correction factor, and then an end luteal phase with a stronger basal and a stronger correction factor. So yeah, I guess it's kind of knowing your algorithms and knowing what's about to come up, and seeing how decent they are. So what's been your perspective so far on the different systems and how they're able to handle that? So you've obviously described the 7HG on those 12 people. It suggests that it's able to do a pretty good job, certainly better than people on MDI would do. What about the
Of
other ones?
course.
Have you got any perspectives on those?
Yeah. Okay. So, first, I would like to say that considering 170 patients, girls with type 1 diabetes, it's different than considering just 12 on one system. So you have to really think through what you're doing when you're doing it. And also think about the fact, like, not everyone has, premenstrual symptoms. Maybe not everyone has, the same changes on their insulin resistance during the menstrual cycle. So we started to think about, okay, how can I deliver actually this difference that maybe there is between, the women on MDI and the women on AIDs. And so I said, okay, let's look at the girls that have what I call the deteriorating cycle. 5% of time and range decrease between the phases. And maybe I will change this, I don't know, but for now it's like that. So I looked at the percentage of girls on MDI that had actually this deteriorating phase, for like more than 5% actually of decrease in time range. And there were like 60% of them. So a lot, actually.
Mm-hmm.
And in this case, I wasn't even considering the ones that actually did something with their doses, because, of course, some of them start to think about it and start to do something with their doses. So I still not considering them, just looking at the raw data from the CGMs. And then I looked at the same thing in the girls on AIDs, and I saw that globally, depending on the algorithm, they have this decrease only in the 30 to 40% of cycles. So it really means that AIDs, even if they don't factor in the menstrual cycle, even if they were not designed for that, actually do something on broader, missing the word. Sorry.
Yeah. So, I mean, from what you've described to me, what you're saying is for the 170 people, you said, look, from the early follicular phase to the late luteal phase, we're going to say if your timing range drops by 5%, you fall in the category where the menstrual cycle has an impact on your timing range, regardless of whether you do or don't do something on MDI.
Yeah.
Okay. And then 60% of those on MDI actually had that deterioration, which basically means over half of the women are unable to keep on top of the change. As if you're calling 5% clinically important, which I think most people would agree that is clinically important, something that's going to happen once a month all the time, that's something that's important.
Yes.
But then when you look to the same people on AID, not looking at any ID specifically, that dropped by half. It went from 60% of the people down to about 30% of the people. So it shows that these AID systems, from your data, are able to improve things by half, which is amazing. But that still leaves 30% of women with that deterioration on AID. Did you notice any difference between the type of system? Was there any difference between the type of system that was meaningful, or could you not get that level of granularity yet?
Well, I started doing like some really, really early analysis. First on the first data. Now I have all the data and I have to do the complete one. But what I did see is actually that the control IQ system usually is quite stable. And we also have a study in literature from 2022 that says the same thing. Even if we consider that they didn't switch the profiles. I mean, we have adolescent girls, they don't switch profiles. It's just impossible to have them do that. And so it's quite stable, actually. Maybe they do have the hyperglycemias that we were talking about, but, you don't see any dramatic change in between the phases. So I think that it's quite nice. What I'm saying here right now is not about ranking, the systems, because I think that,
just observe it, just on what you've observed. And it's important to say that this data we're talking about is observational. It doesn't mean cause and effect, and that's where
yeah,
you're going to next with your thing. So,
yeah,
but it's interesting from observational because you generate your hypothesis from the observation data, but what tells you whether that is actually scientifically proven is your next piece, which is perspective. But if we need to dig into the observational and see what you saw, of course we do. So what you're saying is the T-Slim Control IQ looks like it maintains the time in range quite nicely, even though it doesn't have profiles, or they may have not switched between the profiles. However they're using it, it seems to do the job. So that's fine to state observationally. Yeah, it's not cause and effect. You can say that absolutely because it's what you
Okay.
observed.
Yeah.
So what did you observe for the other systems?
For the OP5 and also the 7080G system, I actually observed the same thing. I mean, there is not like so much of a dramatic change, but what the patients say actually, and what you can see, it's a little bit more of a hypos during the early follicular phase, which is, quite logical when you think about how the algorithm works, the things that you were saying before. Okay, when you consider the total daily dose and then you put it in the algorithm as a factor for how much basal you're going to do, how much correction you're going to do, then it's super logical to think that maybe if the total day dose ramps up maybe a little bit too much for this patient, then you have the hypos in the early follicular phase. And that's, I think, that the thing that concerned me a little bit more regarding the quality of life aspect, just the quality of life aspect, because you have this time range that it's not so different before when you consider the early follicular and the late luteal, but then you have the mid follicular that goes like this, much better. What happened here? The system just saw the hypos and started to do less insulin, so it went back up. And so it's so interesting.
So that makes.
Yeah, and when you consider about the study designs, actually, you can't, with the ID systems, you can't compare just the early follicular versus the late luteal, because you have the system that does something in the between, and you have to consider all the phases and the patient perspective, I think.
Yeah, I mean, that makes total sense to me. So, I mean, my interpretation from the observation, not causation, is kind of what you're saying is all systems do not really have a deterioration from the early follicular to the late follicular. They seem to do a pretty reasonable job on average. But as a consequence, potentially from the way that some of the systems work, i.e. they prioritize the previous 3 to 5 days total daily dose to decide whether the algorithm ramps up. The ones that do that, which would be your OP5 and your 780G, the downside is as soon as the insulin sensitivity really flicks to a lot more insulin sensitive, because it's got 3 to 5 days in a bank of requiring quite a bit more insulin, there is an increased risk of hypos. Whereas for the Control IQ, you don't have that. It just then doesn't have the same hypoglycemia risk. Now, of course, this can be mitigated. So as soon as the bleed starts, if you're on a 780G, you just put the target range up for 3 or 4 days. If you're on the OP5, you put the glucose target up from, if it's a 6.1, put it to 7.8 for a few days. Of course, this can be managed. But the fact that that observation is there allows the person with diabetes, allows the clinician to understand what's happening, what the risks are, and most importantly, what the potential solution is. And that's the whole point. All these systems are built differently. They all have pros and cons. If we understand them, if we observe what happens, we have some suggestions to consider that need testing experimentally. But in the medium time, if we know that it's there, at least we've got a bit of something to advise on if someone comes with this pattern and say, oof, I'm on the 780G and I tell you what, it does all right during before the bleed, but as soon as the bleed happens, boom, I'm hypo all the time. Okay, I've heard about that. How about we put a higher target on as soon as the bleed starts? The same for the OP5. And that's the whole point of observing these things, talking about them, offering potentials, and then, getting some research to test whether that's going to be effective is the next step. So I think for me that it makes sense on all fronts. It makes sense that there are options. So if you've observed that, I've obviously thrown out some options for the 7/8 in the Omnipod 5, and presumably you didn't have the Cambridge system available where you are to know whether that works or not?
No, sadly, we have it available, but we don't have many patients right now, just like 3 to 4 post-menstrual. So it's just, about talking about it and saying, okay, you can use the boost function in this case, that it's actually mentioned as something that could be useful, even if it's not studied for that, could be useful also for the intercurrent illnesses as well. And so usually I suggest that considering the KMAPS, but I don't have the data to comment on that like I can do for the other systems.
No, I mean, again, that makes sense because if you put the boost on during that phase, you will get the extra insulin by directionally 30% in the late luteal phase. But what the important thing is, the algorithm doesn't learn from that, so it doesn't learn the extra insulin going in. So then you can just flick the boost off, and then when it comes to the early follicular phase, you won't have that learning incorporated into what it's about to do. So yeah, it makes sense. It's horses for courses. There's choice if you know how things work, and there's solutions if you're on one of those systems. So we've maybe laid out there for people, okay, the all systems are probably all good leading into the to cover the change in timing range doesn't really affect it. If you're on a CAM APS, maybe put the boost on to get the benefits of improved control and then flick it off and you don't get the learning. For the 780 on the Omnipod 5, maybe you need a higher target as soon as the bleed starts to happen for 3 or 4 days to reduce the risk of going low. So we've thrown out some maybe options. Is there anything you'd put on top of that from your thoughts?
Yeah, I was just thinking about this like in the last few days because in our clinic, most of the adolescent girls are actually on the the optimal settings of every pump. Okay, we try to give the optimal settings because we think that pumps like this work better, algorithms work better. So we just try to put everyone in the optimal settings, but we have people that are not. So when you experience the hyperglycemia, we can also talk about lowering your target or shorten your active insulin time. Because I come from a perspective where everyone has the 2 hours and the lowest target, but it's not always like this. And we can play with that, with the active insulin time and the lower target in the late luteal phase and also in the early follicular phase. So we can do a little bit of a switching from one profile to another and see if that works. And that will be my next research, I hope, to try and to give the girls recommendation, like structured recommendation on how to do that and do some follow-up and see if actually we can make them work better for them. When the menstrual cycle is not factored in the algorithm, we try to factor that in the algorithm and change the settings a little bit to see what happens. But that's going to be the next chapter, so I don't know right now.
Yeah, I mean, I think that's fantastic. I mean, I think people listening to this, certainly people who with type 1 diabetes are action takers. So the observational data leans to what we've said. A little bit more insulin is going to be required in the late luteal phase. And if you're on injections, you can do that any way you want. You can put your background insulin up, you can make your carb ratios more aggressive, you can make your correction factors. And what your observational data would suggest, if you don't do those things, 60% of the women will end up with higher glucose levels and a reduced time in range by 5%. So they've got some thoughts there. And also, if you're on an AID system, maybe you don't need to do anything for that deterioration time in range, but you need to be careful on the back end because as soon as the bleed starts and the insulin sensitivity kicks in, for those systems that really look at that sort of learning over the last 3 to 5 days, i.e. your 780, potentially your Cambridge system, potentially the Omnipod 5, you may want to, wherever the settings are, make them less aggressive for 3 or 4 days post as the bleeding starts. And you can do that a number of ways. You can elevate the target level. You can relax the active insulin time. You can use ease off if you're on the Cambridge system. You've got a host of different options. And what you're saying is, these are all the options that are available. What we're going to do where I work now is put this into a structured teaching format, teach it to people. Number one, do they do it is the most important question because all these things are fancy bits and pieces, but are people actually going to do it is number one. That's the difference between efficacy and effectiveness. Efficacy is we think it's going to work, it works. Effectiveness is you give it to people, will they actually do it? You wait and see. And then obviously put this teaching program to the test. Do they use it? And then if they use it, does it and then lead to the outcomes that people would want, which is not having a deterioration in time in range, or maybe even improving time in range, knowing it's coming, and then not ending up with increased hypoglycemia on the flip side. So when can we expect that research to be tell us the answer? When are you hoping for that to be done and out?
That's the question. No,
do you need funding? Do you need funding? Do you need participants? Because if you do, now is the time to say, we need your money, number one. And number two, if you're interested and you live in the Italian area, this is how you would subscribe or get involved. So here's a sales pitch. You go for it.
Here. No, I just want to add
Oh no, you go for it.
First, actually, for this questionnaire and CGM and insulin study that we were mentioning right now and discussing, I had an ISPAT breakthrough type 1D research grant that I'm super grateful for, and so it means that someone is actually looking up on these results. And these first results, I hope that I will have them published in the next few months, so we can move to the other phase and see if the other centers, like in Italy, that's we involved, we still like to be involved. And maybe can we move to an international perspectives? I've got some colleagues from Poland that were really, really interested in the project. And so I hope that we can do something all together actually about this. And I think that one of the things that are most important to me right now is giving this message to the industries. Actually, they're changing their algorithms. They should factor this in because it's so easy. We have, apps on the smartphones that track the cycles that could just be linked. It's so easy. We see many difficult things at congresses, the fully closed loop, the machine learning techniques and everything. And we don't think about, just putting the cycle in the algorithm. And I think that's something that should be stressed. And I hope that, this podcast can give a little bit more of attention on the problem also for them.
Yeah, well, 100%. There's definitely a lot of people from industry listening to this, just to make sure that I'm not saying something which is detrimental to their algorithm or thing first up, probably. But second of all, to get ideas, because the great thing about having people like you reach out, you're in the moment of doing important observational, moving into experimental research on a topic, as we've just said. Number one, it affects half of the people with diabetes, and not all of those half are going to be impacted, but maybe 30% of the total population of diabetes on injections are going to be, 60% of those are going to be experiencing a decrement or a decrease in time in range of more than 5% on a monthly basis for 4 to 5 days. That is going to impact your outcomes in the future. This is an important piece of information or research that is required to be done. Yes, AIDs are improving it, but some of them are leading to, well, you could do better. You could know it's coming through AI or whatever your algorithm and increase the insulin. So maybe you get improved time in range rather than just okay. And then also on the flip side, being careful with the hypoglycemia after you've elevated that insulin should be able to be worked out from an algorithmic perspective. And also the question of, which systems would benefit from this the most? And you're trying to answer that question by offering real life strategies to people on these systems. Number one, will they do them? And if they're not going to do them, then it needs embedding in the algorithm first up, because people are not going to do it. And that piece of research would be amazing on its own. And if people do it, what are the strategies that really work? Therefore, that's what the algorithm should be incorporating. So, what you're proposing to do and what you're suggesting to me has massive impact, makes a lot of sense. And even for the people who are not going to get the opportunities to use an automated insulin delivery system, it's hopefully given them, wow, okay, this is pretty predictable as long as my cycle's predictable. I've got options with increased background insulin or stronger correction factors or, stronger carb ratios, maybe more activity post meals. If it's coming and for most women, it's going to deteriorate their glucose control and it's going to be monthly for a long period of time, it's something worth investing some time, some thought, some energy into. Now, I just want to say thank you. I'm obviously not a female, so I'm not going to directly benefit, but I know that there's loads of people reach out to me who say, what you're saying about women with type 1 diabetes, there's not much out there. You're not doing a great deal in terms of, talking about it. And part of the thing is when it doesn't affect you personally. I don't have a menstrual cycle. You don't see it impact your glucose levels on a daily basis. You might hear about it and think about it, but if it doesn't hit you personally and hit you hard, of course it doesn't have the same effect. But you've experienced this personally. You speak to females and ask them the right questions and understand the impact them. You've got 170 people telling you exactly how it's impacting. So now the conversation is open. There's a little bit of research being done. Yourself is looking for Italian collaboration, international collaboration, research monies. You've got the drive, you've got the skill, you've got the energy to do it. So I would encourage anyone who's listening to this to kind of go, okay, this lady, she's moving, she's shaking, she's got something important to say or find out. She's got the tools and the research skills to be able to do it. And, you've been through the ISPAD science school kind of, you're on the right path and all that business. So, I'll just encourage people to reach out to you and, give ideas, give money, give a sense of who's interested, because you're quite right. Having an international 2, 3, 4 centers is so much more powerful, because if it happens in this corner of Italy, who really cares? But actually, if it happens here and it happens in Poland and it happens in the US and it happens here, actually, this happens everywhere. Yeah, it does. Of course it does, because they're all females at the end of the day. So maybe slightly different physiologies, but not that much different. I just really encourage people to reach out to you. We'll put your contact details. We'll put your kind of links to how people can find you. And certainly when your paper is published, drop it to me. I'll get it on there. I'll pop it in the newsletter. Because I think the observational data is actually so interesting from hypothesis generation, mostly because the bit that I was really interested in is like, it really pisses people off. Like it's not a small thing. It's something that's impacting them on a monthly basis in a serious way. And that alone requires attention. So I've just totally rambled and tried to sell this thing for you, but I think it's a really important thing to do. So if people do want to reach out to you, where would they get hold of you?
I would say LinkedIn. Even if I don't post that much, I read on LinkedIn and I answer on LinkedIn if you text me, if you send me a message. And I would say also Instagram or Facebook work well, whatever. Just try and reach out, and please, John, put my email also there. I think that sometimes, social media, it's easier because you don't have like the spam on that. Sometimes some emails go into the spam. So I would say LinkedIn, Instagram, and Facebook are actually the best options right now. And so I can't wait, to publish all of that, to finish this.
Yeah, and absolutely.
To see what happens.
I'll absolutely put all those handles in the show notes, and I will make sure that it's kept up to date on the page with actually when the research gets published, so that people can kind of check out what's happened and where you're up to as this important area. And I'm sure Jen Yardley's probably listening. If she's not, I'm going to give her a nudge as well and say maybe you two need to have a conversation. She's someone who's just a very interesting person with some great ideas, and I'm sure she would also have some amazing contacts of people who are interested in this space in terms of international. So I want to drop her an email afterwards and just sort of introduce you guys and say hello. And obviously overstep as many boundaries as I can. But yeah, I just want to say I appreciate you. I want to say thank you for reaching out to come and have this conversation. I have learned a lot, and also it's really going to help my personal practice, because I now have an idea what I'm talking about, what I'm looking for, how much it impacts people, and what directionally I can do, both with injections, pump therapy, and MDI, to help people combat something which is really annoying. I don't think I can do anything for the craving for pizza, obviously, but I can probably do something from an insulin perspective to make sure that doesn't cause as as many problems as it probably does. But yeah, so thank you for reaching out, and I hope that this will get a little bit of exposure, will get some people to contact you, and you can kind of get your multi-center international study. And when you find out what the best things are to do, you can come back on and tell us what the situation is.
Thank you. Thank you so much, John. It's been amazing talking with you, talking about this, because it's not talked about that much. And I really hope that I can bring something else to you in the future. Thank you. Thank you a lot. It's been amazing.
Perfect. Have a nice Christmas.
You too.